Good morning, friends. Welcome to this very interesting session on ophthalmic routine clinical practice. I think there are very small things which makes a huge difference in our clinical management of patient diagnosis, through various examination, investigations, then making them applicable to patient care. I think this is a session where we like to take you through various important small steps of doing particular procedure, and that's going to make a huge difference. And we as a society of Indian Society of Cornea Keratorefractive Surgeons have been doing these type of investigation related or clinical test related sessions in various conferences. And this is, I think, second time in the midterm. Last year also we did it, Patna also. And this meeting is going so greatly. I think futuristic midterms meetings will become a better meetings for future. But I'll request Dr. Rajesh Sinha to convene the meeting.
Thank you, sir. A very good morning to all of you. We begin the session, and our first speaker, the slight change in the order. The first speaker is Dr. Mehul Shah, who will be talking about intravitreal injections of antimicrobials.
Good morning to all, and thank you Dr. Rajesh Sinha and Dr. Titiyal sir for allowing me to be here under their privileged leadership. So we will think about injection first with this study. This is the benchmark study, endophthalmitis vitrectomy study, which has stated some important it has made certain important statement that all endophthalmitis may not need surgery. Anywhere vision above hand movement can be treated and should be treated primarily with antimicrobial injection. That's what is base of our this condition. And these are the microbial doses that is all available and everybody knows. So these are the conclusion of EVS. Intravenous antibiotic used at the time has got no additional benefit. Immediate vitrectomy is of significant benefit to those who have only light perception vision. When the vision is hand motion or better, a vitreous tap and intravitreal antibiotic here has efficacious and recommended. So these are some pre and post picture. Treated only with intravitreal injection. Patient presented early, injection given, and end result was normal eye. No surgery has been performed in these cases, but in this case, later on surgery required, but we can see that the infection is gone. So it is important for all to understand what will be the preparation of intravitreal injection according to the endophthalmitic vitrectomy study. Vancomycin and ceftazidime are the agents which are recommended. So this is how we prepare, and I think all information is available online. But 500 milligram vial, and withdraw entire content and saline, add saline to increase total volume of 10 ml. Place 1 ml above the solution and 5 ml syringe and add 4 ml of saline to total volume 5 ml. Resulting solution will be 10 milligram per ml and 1 milligram or 0.1 ml to be used. So these are the preparations of ceftazidime, preparation of gentamicin, amphotericin B. These are the most common agents what we use. Prior to the procedure, we need to reduce the intraocular pressure, and for that either we use mannitol, because if we want to use two agents, then we are going to increase almost 0.1 ml content. So either mannitol or paracentesis is to be done. This is a small video about the procedure. Two separate syringes are prepared. That's it for today.
Thank you, sir. Any question or any comment from anyone? It was very nice and crisp presentation. And just one query, like if you give intravitreal injections of antimicrobials, so do you tap for this, or with
Yes.
which needle will you use to tap, or would you like to use a cutter for that? What
Not
is your
always,
recommendation?
but if the severity is more, we definitely tap, and we use definitely vitreous cutter.
Okay, but
Because-
in large majority, which needle will you use for?
30 gauge.
Okay,
Not for tapping. We
for-
don't tap with the needle.
Uh-huh.
If it is to be tapped, we remove that aspiration thing and then collect in the syringe.
Uh-huh.
The cutter aspiration port is
Cutter
to be
aspiration.
replaced
So
by
through a trocar
one tube
and,
then you use the syringe
Okay.
when you use the cutting, so that it will not cause any traction on the peripheral retina.
Okay, so these days it has become easier because of the 27 gauge trocar, and you can use it and take out the sample easily,
So we use
sutureless.
trocar, connect the aspiration port with the syringe.
Yeah.
So directly we connect into that,
Yeah,
and then tell laboratory people to use the cytospin to do the cytology as well as culture both.
Okay.
Because cytology also will be helpful to know the things.
So how do you select case for that? Like where will you do it and where will you not take any sample?
I think if the cases are very mild, we see that the blanket therapy will work. But if the case is severe, then we don't have time to wait for blanket therapy. So in first instance, we have to send this sample to the laboratory. By the time if effect starts, next day again we will repeat the injection.
Okay.
If it has responded, but still if we think that the infection is still there, next day we inject again. And then even if it is not responding, then straightway we go to surgery.
I think intravitreal injections have become norms of managing not only infection cases, even for people for our retinal condition.
Anti-VEGF.
Anti-VEGF, so commonly used, and I have seen patients where intravitreal given aminoglycosides and entire macula is infarcted.
So vancomycin is a safer drug for that. If we use gentamicin or amikacin, they are dangerous drugs for cornea and macula both.
Any tips to know how to put the needle so that it doesn't go towards the
The needle will go perpendicular to the sclera, and you inject in the center of the globe. So that will help us to deliver the things, and if possible for injection, use 30 gauge needle, then 26 gauge.
Dr. Mehul, we get a lot of cases of trauma where we do anterior segment repair, sometimes corneal repair, corneal scleral repair. Do you recommend giving intravitreal?
All open globe injury during repairing intravitreal has to be a protocol.
Okay. What should be the common protocol for that? Which antibiotics?
Normally these two blanket vancomycin ceftazidime, but if we find some vegetative injury, then amphotericin B also can be added, because open globe injury has got mixed type of organism, and we are not sure that which type of organisms are there to contaminate the wound. Because we have seen that if the cases are repaired fine on table, third day patient will present with the severe endophthalmitis if intravitreal injections were not given.
I think that's a very important point, especially open globe injuries. Some sort of prophylaxis has to be given to
I
prevent.
think both intravitreal as well as subconjunctival,
Yes.
both has to be.
Very good. I think he showed a nice video where entire conjunctival sac was put with the betadine. You wait for some time, let the betadine take action, then inject. And while withdrawing the needle, also they were putting pressure with the swastik soaked with the betadine. So
Prior to injection, we have to make eye little softer. If we inject 2 injections, the pressure will become higher, and already painful condition, it will cause more pain. So either we do the paracentesis or we use the mannitol.
Thank you, sir.
Thank you.
Thank you, Dr. Mehul. Very nice presentation.
Okay, we move on to the next speaker. A little change again in the sequence. Dr. Vanati. The next speaker is Dr. M. Vanati, who will be talking about intracameral gas injections in acute eye drops.
Thank you, Dr. Tityal and Dr. Rajesh, for having me in this nice session here, focusing on ophthalmic procedures. Though the heading is concerns, but I'm going to talk to you largely on how you would go about managing the surgical management for a case of eye drops here. So these are the various steps which are the concerns which are related to case of corneal ectasia and keratoplasty. But eye drops is something which most of us would have encountered and seen in cases of ectasia, largely keratoconus, and in pellucid marginal corneal degenerations. So we'll skip with all the literature and with all the basics on presentations. So the medical management, we are all aware that we would start these patients on hypertonic saline, antibiotics, steroids, and adjuvant therapies with anti-glaucoma. The surgical management largely centers on intracameral gas or air injections for these patients, which you would probably do in combination with compressive sutures here, not delving into the other surgical modalities, but the common one in management of corneal eye drops here. So the tips or the points which is to be remembered is that when you are using gas, it has to be a non-expansile gas preparation is what is recommended. So when you're looking at C3F8, you wouldn't want 14% of C3F8, and for SF6 is about 20% here. So the surgeon has to be familiar with how the preparation is to be made so that it is non-expansile. So that's going to be the first step which you need to be aware of. The second one is when you're gas filling a patient, you would in the anterior chamber, you will have to advise them against air travel again. So you'll have to be aware for how long the bubble is going to be staying in the AC, and accordingly advise the patients here. So you would find SF6 stays about a week to 10 days, and C3F8 would be a longer stay, and so about a month. So you're going to be advising your patients not to undertake air travel when you're air filling or when you're using gas for the management of corneal eye drops here. The other point which you can use is the use of anterior segment OCT in these patients. The ASOCT helps you to look at the intrastromal clefts. It also helps you to delineate where the Descemet's membrane is ruptured. So these are the two clinical points you would want to look at when you're looking at the use of diagnostics in imaging corneal eye drops patients. The third point is, if your preparation of intracameral gas is not being optimal, and you would land up with an expansile, and this is a complication which I had to face in one of my patients here, and the gas expanded further and the patient landed up with a malignant glaucoma. So that's going to be another clinical concern which you have to be aware. It might look like a very simple, straightforward procedure of just putting in a bubble into the AC, but one has to be aware of these concerns when you're going to look at here. Because of these, I think largely now the what the advocacy is that you probably will not want to use intracameral gas in management of eye drops, and you will switch to a combination of combining compression sutures along with air so that it affords you better safety in the management of these patients. So that is the latest recommendation on these patients here. This is the video courtesy Dr. Sunita from LVPI here. So when you're combining it with compression sutures, identifying where your Descemet's had ruptured is really helps on. So placement of sutures according to how the Descemet's had ruptured really helps you. Remember to bury these sutures here, and when you're using compression sutures, you probably will not need to use intracameral gas, and simple air injection is more than enough in managing these patients here, and that's a much safer approach, and it helps you to be problem free in the postoperative period. And you would find a very remarkable corneal clearing which happens rapidly in these patients vis-a-vis just using a intracameral gas or air injections. I think lack of time, I wouldn't run through the others. I'll just run through. This is another unedited video of one of the recent ones which I had operated. So here you're having this patient, and as you can see that it's very difficult on this particular patient because of the extensive edema. We are not able to see the pupil here, and we were also not able to map the region where the rupture is ruptured. But when I looked on closer, you can see there's a triangular rupture or the triangular deficiency on the Descemet's membrane here. So you would again trying to image it on the IOCT, if you have one, also helps you to delineate it better here. And you will probably have to place multi-directional sutures here in order to oppose or help in the apposition of the Descemet's which has got ruptured here. In this particular case, there was a point of significant thinning as well, so there was a mild shallowing of the AC as well as I was suturing here. So these are particular concerns which you would look at when you are managing a case of corneal eye drops here. Once the compression sutures are well placed, and then you would see that the injection of air into the anterior chamber is by a simple self-sealing stab incision from the limbus here. So there you see air being injected here. For air, then I put a 3/4 fill, but when you're putting in gas, you would probably want to use a 60% fill only of the anterior chamber, and it would also help if you could dilate these patients here. So that's a concern. But if it's a phakic eye, you're having gas, when you're dilating, then cataract and the lenticular opacity is another concern which you will have to look at in these patients. I largely have stopped using gas for eye drops following the malignant glaucoma case which I did have. We did go ahead and manage him well, and he does have 6/12 vision, but that is when if you have a timely pickup for these patients here. So now largely compression sutures augmented with an intracameral air injection suffices well in a problem-free management and early resolution of cases of corneal eye drops. Thank you again, Dr. Tyal and Rajesh, for the opportunity.
Thank you, Dr. Vanati. Just a couple of questions. One is that some people inject gas and do a small inferior PI.
Yes.
What is your take on that?
I think now when we have an alternate method which is proven to say that why do I necessarily want to go in and do a more extensive procedure, so that's something which I think it works in a scenario where probably the patient cannot come back to you and you feel is coming from a peripheral place, and then you're going to do. But still a PI is really not required if you're sure about your non-expansile thing, and you put a 60% fill, and you could probably keep your patients on short-acting mydriatics. It works.
Yeah. And the second thing is that if you put compression sutures, so once the eye drops resolves, then there will be some marks of these sutures as well.
The corneal edema by itself is probably going to alter the stromal collagen clarity here. Yeah. So probably I think what we are looking at is giving as early a resolution, and the longer the edema is going to stay, the longer it's going to be the haziness in these cornea. So we are probably aiming at earlier resolution so that it flattens the cornea much better, and in cases we do find it becomes more amenable to contact lens fitting because of the flattening in these cases as well. But people again do other modalities of surgical interventions like PTEC in cases of high drops as well. So that's something which is a little more advanced, but simple air or gas injection done optimally with or without sutures perhaps suffices well.
Thank you. Sir.
Thank you.
Thank you, Dr. Vanati. And I think you covered the initial discussion about need for early, probably because of the scar. So thinking aloud with all of us here, full thickness suturing is something that all cornea surgeons are
True.
little skeptical of. And that too in the setting of probably a loose edematous cornea.
Absolutely.
Are there concerns of introducing organisms as we go? Because these patients
Yes.
will be on steroids also
Absolutely.
to go forward. So this is
So
something
that's
probably we
something,
could
yes,
discuss
yes.
and
It's
ponder
important
upon.
that you look at the ocular surface of these patients here, because you're doing full thickness sutures, and you feel if it warrants, you could probably do a conjunctival swab in these patients to look at a preoperative conjunctival swab, so that you're optimally you're managing. And most of us, when we are giving steroids, QID, high potency steroids, or low potency, in a setting of compromised cornea, we always cover it with antibiotics. So most of the time the patient probably would have been on 24 to 48 hours at least. So if we see the patient the earlier day, the next day we call him and you do have a 24 hours. But that's a point, because infection is something which can complicate a scenario of high drops. One question to you, Arvind, is when would you go and remove these sutures? What is your practice in removal of sutures in these patients?
So what we have seen is that the clearing is in hours,
Yes.
not really days.
Yes.
So and we already have a gas which would stay for a 3 days or 4 days at least if we leave a 60% bubble. Probably a early removal, like 6 weeks or maybe within. It's
Yeah.
again very case
So
specific.
as soon as you
depending on-
find that the edema
Yeah.
has come down to the maximum possible
Yeah.
resolution,
True.
and it's really not contributing any further, then you
True,
could probably.
true. And also
That's
with
what-
the background of DSEC and DMEC, our understanding of the way the functionality of the desmase changes, meaning once it attaches,
Yes.
the functionality returns. We
That's
do not
true.
need any
That's true.
augmentation
Several times
beyond
I think
that.
it does get
Yeah,
you
yeah,
good.
true.
Thank you.
I think looking into these cases of high drops, if you have a small tear, comfortable if you inject the gas, if you don't get intrastromal gas pockets, then I think suturing may not be required in such cases. You can manage very well with the air and gas in those cases. The cases where you have multiple large tear and when you inject the air or gas, it goes into stromal pockets, which is very difficult to take out. Those cases you may require a compression suture. I don't practice as such, not dealt these cases like that. So maybe if you have multiple pockets happening where the gas is repeatedly going into these areas, suturing might be helpful in those cases to tamponade that area also. Otherwise, simple tear where you inject the air and bubble really works well, then I don't think suturing will be required in such cases. And if you do a good examination, what Professor Vanati showed the anterior segment OCT, you can picturize the area of a desmal tear and how large, how old it is, and you can decide on that. Sometimes the old cases where you have already some sort of fibrosis in the flap, whatever you do is not going to tamponade. So those cases you require a more aggressive approach. Maybe the gas fill is for a longer period. Suturing may be an idea in those cases. And if you have the access to AIOCT microscopes, you can see what is happening on the table also. AIOCT guided management has been described by Dr. Namrata et al., which will also be very helpful to assess your cases and effectivity of a tamponade having these cases. As we look into all these cases, if you see carefully, you can see all of them very, very carefully. And as Dr. Arvind talked about, if you inject the gas, if tamponade has happened, the cornea starts clearing on the spot also. You know that this is going to work for your cases. Other important thing, recently many people who are actual corneal surgeons, they have done dark also in patients with high drops also, and they have reported good outcome in these cases. So that is also one option if you are feeling that your intervention may not suffice, especially repeated gas injection. The people might do a lamellar procedure in those cases and get a good tamponade happening in those cases. But it is a situation. Sometimes in our days, younger days, the cornea is to clear away. It will take more time. There may be more scarring, but ultimately cornea settles down, because that's the property of this thing. All these intracameral gas injection or whatever you do, that is to enhance the rapidity of clearing of cornea, and subsequent scarring will be less. And if it is a keratoconus, the scarring always helps sometimes. If patient lucky, it will be little off, paracentral, and this scarring also causes flattening and the vision improves in some of the cases also. So this is a one routine practice. You might see one case in 2 or 3 years, but we should know how to manage these cases also. Thank you, Anati, for a nice presentation. Hey, one more question. Sorry, Rajesh. You talked about SF6 and C3F8. From where these gases are available to general people, and how do we make these gases? If you can highlight that.
I think surgical grade gas cylinders in the OTs are available. I'd already had in my slide how they will have to dilute for SF6 and C3F8 here. And actually, the privilege of RP Center is that our nursing staff are really trained in diluting this. But I think most of the surgeons, if you're outside, then you would learn your dilution of how much you will have to draw from the cylinders. Yeah, yeah. Yes. So you will have to draw the percentages exactly for SF6 and for C3F8 was already there in my presentation. So I think when this is online, they would be able to read it out.
See.
Yeah, Arvind.
Yeah.
I use this as a very simple technique. So what I commonly use is the C3F8, which is available with retina colleagues. It comes in very small canisters, like how deodorants would come essentially. So one needs to use a air filter, again very commonly available in the retina theater only, and take a 10 cc syringe, and of that we draw 1.4. So we can't get 1.4, 1.5 let us say, and then draw rest as air. So that gives, multiplied by 10, it gives a 14%. It's a very simple way in which one can remember.
Thank you, Arvind.
Next we have Arvind only. So Dr. Arvind will be presenting on intrastromal and intracameral injection of antimicrobials.
Any questions from I can see 2 or 3 young people sitting here. No?
So a very good morning to all. Thank you, Professor Tityal, Professor Sinha, for the opportunity. So I will be discussing on the intracameral and intrastromal injections of antimicrobials. Primarily, this will be in the context of antifungals, because that's where there is a dilemma of what do we do when we fall short, because most of these organisms are deep-seated, meaning fungus, and the drug tends to stay on the surface and penetration is questionable. So when we reviewed the subject of fungal keratitis, we found that there is a tremendous phylogenetic diversity and a lot of treatment modalities that are described for fungal keratitis. And this is just a representative slide which is part of a study that we are conducting on understanding the fungal microbiome of the ocular surface. This is a corona chart. What it shows is that what are the different phyla that are there on the single swab that is taken from the ocular surface. And we see that the common families are Ascomycota and Basidiomycota. This is a common conjunctival swab, and this is the type of fungi that inhabit it. What is surprising is that 29% of these fungi are unclassified. Number 2 is that when we look at the Ascomycota and Basidiomycota, again there are a lot of gaps there, lot of unclassified fungi, meaning that even if we understand what the genera is, what the order is, we do not know what the species is, and we have very limited bullets or magic bullets to treat them. So it's important to understand that what else can we deploy in this situation. So probably our studies which came up in a decade earlier were very encouraging that intrastromal injections tend to work. It provides a targeted delivery of a drug deep into the cornea, and it is relatively safe and efficacious. More on that later. So what are the drugs that we employ? Primarily voriconazole, amphotericin, natamycin in the sol form. The concentrations are typically, if we use voriconazole, 50 microgram in 0.1 ml and amphotericin in 5 microgram. So it works by providing a depot close to where the organisms reside and tends to kill it there. So even if there is a delayed penetration or slow absorption, by a targeted delivery we can achieve resolution. This is the technique in which I inject the intrastromal drug. So typically we use a 29 gauge needle and inject it into the middle of the corneal stroma, and as the drug is getting injected, we can see that there is a hydration of the stroma, and one needs to create a barrage of this hydration throughout the entire extent of the corneal lesions. And this is done 360 degrees. We can repeat it once again within 24 to 72 hours. Typically, we do not recommend injecting more than 3 times. 2 times can be done. Many cases even resolve with only a single injection as well. So then the subsequent studies came up which also again showed that no, this is not really the case when we conduct it in a study setting. Now, it is important to understand that this is a study setting, meaning that there are a lot of things that are controlled over here, parameters that are matched, and we find that the demographic success, treatment success, everything is matching whether we give intrastromal voriconazole or whether we give topical voriconazole. So now where do we stand? So where we do stand is that if we cannot do intrastromal voriconazole, fine, the topical also works. But if we can do, if in a case by case basis we inject, probably that is one more approach in treating a deep seated fungal infection. So with this background, I will take you into 2 case scenarios. This was a diabetic male who had uncontrolled sugars. He presented with a typical fungal appearing lesion. You can see that it's a dry, feathery, indistinct margins, and this patient had a visual acuity of finger counting, and on scraping he had filamentous fungi, Fusarium species. On natamycin he continued to worsen, as we can see that the surface lesion is becoming constricted, but the deep seated endoexudates are there. So as we can see by day 21. So that's where we thought that now it is going deep in spite of natamycin, which is again we know that will work well with the Fusarium species. So we decided to give intrastromal voriconazole in this case, and he started resolving slowly, and this was the resolution after 11 weeks. 11 weeks of intrastromal voriconazole with the topical antifungal. So even if we give the intrastromal, the antifungals need to be continued, and one has to see whether it is responding, and response doesn't happen in 3 days to 5 days. One has to observe closely and then take a call in 1 week, 6 days, 2 weeks, and so on. Now if we contrast this to another case where this was aspergillus, now we understand that aspergillus is a even more virulent fungi, and this was a patient who came with again uncontrolled sugars and a 1 month history. So here we can see there is a dense plaque, a dirty blood tinged hypopion that was there, and what's also happening is that there is a leash of vessels that is coming from the limbus, and here we see that very early it is involving the infiltrate is involving the limbus. Now fungus, when it involves or starts threatening to involve the limbus, it's always best to go the conservative manner, meaning that completely remove it, extirpate it, remove it with a therapeutic PK, because hoping against hope that an approach of intrastromal might help will only lose valuable time. And we did a therapeutic PK, but again this did not work. There was AC recurrence, scleral extension, and ultimately the graft failed and the eye was prethysical. So there are 2 things. One, we need to understand the context clinically when we have to or when we can inject intrastromally. Second, even in spite of best efforts, if there is a continuous progression, then therapeutic and timely therapeutic is probably important. So I just meant to present a balanced approach on intrastromal and the way literature is understood, the way it behaves in the clinics, and the diversity of the organisms that we see, because we don't really understand the different varieties of fungi that populate us. This is a brief video on AC wash. Again, it is primarily a debulking procedure. What we do is that we remove all the endo exudates or the exudates that are there at the back of the cornea. This tends to debulk it. We inject it with we inject intracamerally, again at the same concentrations, the antifungals, and we also, if needed, depending on the melting or perforation, we tend to inject the intrastromal injections as well. So all in all, these steps help in debulking, giving the drug directly at the site of infection, and observing clinically the response. At the same time, one needs to understand that what is the systemic status, how long this patient has been here, and how long the antifungals have been used, and whether we should take early surgical interventions like therapeutic peaking. Thank you very much for a patient hearing.
Thank you, Arvind. You nicely covered the entire procedure of intrastomal and intracameral. He talked about the indication of cases where you need to approach these cases with intrastomal and intracameral, and technique of injection of intrastomal is also very, very important. Nicely highlighted the barrage technique and repeatability of injection, at least maybe within 24 hours or 48 or 72 hours, because this life of what drug you are injecting is very short, and maybe it's effective for that particular period, and that will control the risk. If needed, you need to repeat these injections.
True.
And other important aspect of intracameral or intrastromal injection, apart from selecting the right cases, avoiding the complication happening in these cases also, because these are inflamed eyes, the cornea may be edematous, sometimes maybe thin, so you have to have a precaution be taken to not to damage further in these cases. I think the intracameral thing, we have reported various complications of intracameral injection, wash. You can have hyphema formation because iris is so floppy, vascularized. You can have a huge hyphema happening in these cases. Cataract formation is another challenge for these patients in intracameral injections. So those aspects should also be looked into. But yes, if you look at therapeutic value, it has a definite therapeutic value. If you have the proper identification of organisms and if you have a sensitivity also.
Yes, true.
Very nice, Arvind. Any questions? Because this is a commonly done procedure by us, like intravitreal injection. We also started with intrastromal, intracameral injections. Intracameral has been there since the intravitreal injection days. Intrastromal came in last 1 decade only, and this has become a very important part of treating infectious keratitis.
True. So I think as we go forward, we also need to understand that there are many new molecules that have come up in treatment of the fungi, such as posaconazole, for example, which is gaining a lot of interest. But at the same time, with due respect, there are some old molecules, one of which is amphotericin B. It is tremendous. So sometimes there is a disdain for anything that is old and but that's not the case. As we understand more of the organism, we know that we actually know even less than what we started out with.
That's absolutely true. In fact, recently we have analyzed all our fungal, isolates and their sensitivity to antifungals. To our surprise, most Aspergillus strains are now resistant to natamycin.
Yeah.
And natamycin was the only drug available for all these cases. So you can imagine what will happen to these patients. You have to shift to a newer generation medication like posaconazole, which we talked about by Arvind. So we have to always titrate what is the sensitivity pattern of these organisms and change your antifungals or antimicrobials for these patients. Thank you, Arvind. Very nice talk.
Okay.
The question is role of
Oral
antifungals.
antifungals.
Yes, sir. Very nice question.
Very nice. So I think the role is again like intrastromal. So there are papers supporting it, there are papers which are refuting it. So if you look at the MUT2 trial, The MUD2 trial very clearly did not show a beneficial effect of combining oral voriconazole. We don't give oral voriconazole. Commonly we give ketoconazole, same class of drug, but that was not what was studied. Again, when there is a systemic absorption, there is a hope that it might work. So there is technically, there is no limitation that we should not use it. But again, the drug is in the eye, and we are exposing the whole body with drugs that are given 2 times a day. And it's good, sir, you discuss this question. What we are also beginning to understand, if you remember the chart that I showed, more than 50% of the fungi we do not know what they are. And we are living in an ecosystem where there are pesticides of all types sprayed on the food. There are very different types of fungi that are in agriculture, which we are only sustaining only a very part of it. We are like the end of the chain for them. So the answer is out there. We really do not know that, basically. But having said that, yes, we can prescribe. I think in a very simple answer, yes. Extremely important. Diabetes, you said, right? Yeah, extremely important. Unless the sugars are not controlled, the fungal keratitis will be extremely resistant to treatment, no matter what we do. So it's very crucial, because there are changes in the molecules when there is constantly high blood sugar levels. Second, the immune mechanisms are compromised. So definitely the organism is going to thrive in the deeper layers of the cornea. It's not going to go away.
I think the point is well taken. The systemic control has to be there for anything, and it's more true for an infectious disease. And infectious keratitis would also be into that line also. And diabetes, one of the risk factors for a fungal ulcers, it has to be under control. And sometimes the ulcers are so severe, so you are bound to use all the routes of giving these medications. You do intrastomal, intracameral, topical, and systemic is desirable in these cases. But fortunately, all these systemic voriconazole, what you give is not too toxic. So you can give it for a long time also. Only thing you have to look for a KFT, LFT for these patients, monitor that, and you can give it. But we don't know exactly, as Dr. Arvind said, how effective that will be in combination with other medication. But no harm, especially large ulcer, not responding, threatening the limbal area. You might give pediatric patients. We don't know. We don't know the actual result of these voriconazole, ketoconazole in pediatric patients. So you have to be a little careful there. Patient nursing the baby or pregnant ladies, you have to be a little careful in those cases. Now we'll take you to the primary aspect of infectious keratitis, where to diagnose them, you have to do a proper examination, a proper scraping to get a proper tissue for giving either for culture, staining, smear, so that you can do a good diagnosis for your patient and implement the treatment of these patients. We have Dr. Manpreet Kaur. She's assistant professor in the cornea department, RP Center. So she's going to take us through the techniques of corneal scraping. Though it was the first talk, but doesn't matter. We have to learn this also.
A very good morning to all of you. So I'll be talking about corneal scraping, the right way to go. There are no financial disclosure. So corneal scraping, as we all know, is a superficial keratectomy procedure to procure samples from the corneal infiltrates. So what I'll be covering in this presentation would be why to do corneal scraping, when to do corneal scraping, and how to do corneal scraping. So why? It's the cornerstone to the management of microbial keratitis. So even experienced cornea specialists, when they rely on typical features of feathery infiltrates or a dry looking ulcer, etc., they can diagnose bacterial versus fungal correctly in only 2/3 of cases. 1/3 still you cannot come to a diagnosis even with clinical experience. Then the typical features of fungal keratitis, such as satellite lesions, feathery margins, etc., are present in only 30% of cases, and the rest may not be that easy to make out based on your clinical examination alone. So corneal scraping is imperative. You do a smear gram QH, which will give you a rapid clue to diagnosis to initiate the appropriate antimicrobial therapy. Then a bacterial or fungal culture will help you identify the causative organism and do speciation. And sensitivity, of course, in this era of emerging antimicrobial resistance, you have to tailor the management appropriately and identify drug resistance. Coming to the indications, when to do corneal scraping: central large corneal ulcers with or without stromal involvement, chronic infections, cases refractory to ongoing treatment, previous history of any surgery, post CXL, post LASIK, post transplant. You have to do a scraping and suspect infection. The index of suspicion has to be very high. Atypical clinical features such as radial keratoneuritis, feathery margins, satellite lesions, etc., that point towards a specific microorganism. Multifocal corneal infiltrates. These are the AO recommendations for when you should do scraping. So when can you avoid scraping and do an empirical antimicrobial therapy alone? Maybe in small ulcers less than 2 mm, not involving the visual axis, overlying epithelium is intact, there is minimal or limited stromal involvement, you can get away without scraping. But the rule of thumb should be that if there is a significant ulcer, you should scrape. Initial presentation prior to the start of empirical therapy is the right timing to do scraping. In case the patient presents to you late, often they would be on treatment from outside, still do scrape, especially in non-responding cases, and you can withdraw the use of antimicrobial agents for 24 hours, then scrape and restart the appropriate antimicrobial therapy. Also, if the initial cultures are negative and patient is not responding to treatment, it's another indication to scrape. Before you go ahead with scraping, you have to document the corneal findings. So a colored corneal diagram is what we teach our residents to document. Epithelial defect is shown by green, infiltrates by yellow, hypopyon, and a photographic documentation as well, because it will also help you assess if it's responding to treatment or not. And progression or worsening, areas of clinically active margin, areas of maximum thinning, impending perforation should all be noted. Before you start scraping, counsel the patient, take an informed consent, explain the steps of the procedure. Just don't go ahead with a needle or a blade to the eye. Explain first. Patient comfort is important. Typically, scraping is done on slit lamp under topical anesthesia. Anesthesia in itself may be bactericidal, and topical proparacaine 0.5% has been shown to have the least bactericidal activity. So put the appropriate anesthetic drops, wait for a minute, and then start scraping. So which instrument to use? You have metallic instrument, you have swabs, each come with their pros and cons. So needles are very handy. So we all tend to do scraping with needles. They have a high risk of perforation, and the amount of material that you collect with them may not be appropriate. Then blades, 15-0 blade, Bart Parker blades, etc., disposable, sterile, easy to use. Sampling from the deeper layers is allowed with these blades, and they also in the process debride the ulcer a bit and enhance drug penetration. Then if you look at the Kimura platinum spatula, again a very useful tool. However, you need to re-sterilize between specimen collection, because you have to collect specimens for gram, for KOH, for bacterial culture, for fungal. Advantage is blunt edges and leaves a smoother corneal surface. Calcium alginate swabs soaked in appropriate transport media have a very high culture positivity. The disadvantage, they inhibit PCR yield in itself. However, they are associated with a lesser perforation risk. So in cases with thinning, you can use swabs as well. So purulent material and debris around the infiltrate should be discarded first. Scrape the edges and the base of the infiltrate. Exert mild to moderate pressure, multiple strokes in a single direction, and avoid areas of thinning. So here on the left hand side, you can see a 15 number blade is being used to scrape the leading margins and the base. And on the right hand side, a needle is being used, a 26 gauge needle. So as you can see, the needle does carry a higher risk of perforation and it's more risky. Then what do you do with the collected sample? You have to transfer the sample onto the glass slides to make direct smear. Area is pre-marked with a wax pencil on the under surface, and make 3 to 4 smear and discard the blades after the smear. Don't reuse them, use a new one for each. And then gram staining and QH mount is what is conventionally performed, 2 smears at least, and then GMSA acid fast smears are taken when necessary. So we all know the process of gram staining. It's based on the thick peptidoglycan cell wall in gram positive organisms that take a gram stain crystal violet, and in the thin peptidoglycan cell walls in gram negative it will decolorize, and counter stain is taken with safranin. QH of course you use to lyse the corneal material collagen, and you can see the fungal hyphae. Sensitivity and specificity: for bacterial, gram stain has a sensitivity of 61 and specificity of 84.9%. For fungal, it has a specificity of 99% but a sensitivity ranges from 30 to 98. For KOH, fungal 72.2 to 91% sensitivity and specificity of 99%. Then you have to inoculate the culture media, either direct inoculation, it gives a higher yield, or a transport media may be used. Viral and chlamydal cultures you are collecting Hank's balance solution. So various media are available, and direct plating when you inoculate a culture media do in C-shaped streaks. And if you are using a liquid media like a thioglycolate broth on the right, you have to put in the needle or the swab and don't reuse it, use a new one for the next one. So these are the various culture media available for different organisms. Direct plating of course is preferable. So we tend to bug our microbiology department that what's the report. Do know that it does take time. Aerobic culture you have to wait at least 7 days, anaerobic cultures 7 to 14 days, mycobacterial and fungal cultures 4 to 6 weeks before reporting as no growth. So have patience. Culture positivity rate is 24 to 77%, and a growth is significant if the organism goes on 2 different media. Same organism grown on repeat scrapes, culture consistent with the staining report, or confluent growth is observed at the site of inoculation on a solid media. Challenging situations: uncooperative patient, pediatric, associated desmetocele, deep-seated infiltrate, scraping may be challenging. You may need an examination under anesthesia for uncooperative patient and children. So just to summarize, why scrape? To identify the causative organism and tailor treatment, and check the sensitivity to whatever treatment you are giving. When to scrape? Almost all ulcers except for small central peripheral less than 2 mm ulcers. Anything else you have to scrape. How? Document, counsel the patient, give topical anesthesia, use metallic or non-metallic instruments. Just be aware of the pros and cons of each. Scrape the best base and leading edge. Gram, KOH, culture sensitivity, bacterial and fungal have to be sent. However, scraping may be negative. So what next? You have a host of other technologies that is beyond the scope of my talk. You have corneal biopsy, confocal microscopy, ASOCT, various adjuncts, PCR, and other culture methods are available nowadays in case you have scraping negative repeatedly. Thank you for a patient hearing.
Thank you, Manpreet, for detailing the, we say it a very small step in our management, but it's one of the most effective way to treat your infectious keratitis patient. If you have something in your hand that can guide you how to manage these patients, and properly done scraping and subsequent, staining them, getting a good microscopic examination gives you your immediate attention to change your antibiotic profile or start some new antibiotic for patient. And culture sensitivity will also give you another guideline of either modifying or continuing the same medication. Also, very, very important step in any infectious area also. Now we'd like to invite Dr. Venkatesh, who will be talking on the laser iron.
Thank you, Chris, for this opportunity to cover on AIOCMTC2 for a general ophthalmologist perspective. So I use this template, my dear friends, for glaucoma diagnosis. This is made by myself, a simple visual guide to really start off like a map. So you see cupping, visual field effect, and the IOP greater than 20, it goes into open or closed. Less than 21, it is normal tension. And then normal, and you can see the below category where there is an ocular hypertensor. So, and there is another template. So this template focuses mainly on gonioscopy, which really shows whether the angle is open or closed. So in this template, you can see again, this is again made by myself and my team, where we have in the top, I'm sorry for the hindrance there, it's primary open angle glaucoma, then there is secondary open angle, where you can see that cupping visual field IOP greater than 21, the angles are open to the secondary cause. And then you can see that primary angle closure and secondary angle closure. So these are the permutations and combinations that we encounter in our practice, and majoritively we end up diagnosing whether it's an open angle or a closed angle, be it whatever the primary or secondary cause is going to be there. And angle is something that is we give major importance to currently for treating, especially with the advent era of MIGS and other things, because the drainage is targeted towards the angle structures. So this is an animation of the angle recess. Angle recess is something which is three-dimensionally, you need to visualize it, and it is a site of pathology of glaucoma. So that's why we always talk about angle, because we always direct our treatment towards the angle. So when we talk about a pupillary block phenomenon that happens, right? So we can start off with a simple torchlight examination from the temporal side, where you can see an eclipse sign here. Can I have a pointer? Yeah. So you can see an eclipse sign on the left-hand side where there is a dark shadow. So the dark shadow shows that the light is not falling. Yeah. So the light is only falling in this area because of the hill-like phenomenon here. The light is not falling, suggesting that the chamber is more shallow. So what are the other visual markers that we can see is refractive value for hypermetropic, simple hypermetropia, or it could be a compound hypermetropia. Check your refraction values and check your antechamber depth, whether it is more shallower. If you are doing a slit lamp examination or a biometer, also the axial length of the patient. It may be a simple hypermetropic eye for that matter that we are dealing in. We can pick it up in a simple torchlight examination. So the rule of thumb here is a deep chambered eye almost always will have a eye which is having a wide angle. You can see that when I throw the light from this angle, it completely falls through the other side. Whereas a shallow chambered eye, you can see when the light is thrown, because of the convexity of the iris, it may not really go the other way, as you can see here in the image below. So you will have an eclipse sign which you can simply pick up in a torchlight examination. So why we are bothered about this is a 10-second animation of myself which we have done. You can see that the problem happens here, my dear friends. The posterior iris with the anti-lens capsule. So the aqueous is not able to go through this route because of the pupillary block that happens here. Since the aqueous is not able to go through this route and go through its drainage here, the effect happens here, the cause happens here, the consequence happens here. I'll just play this once again. You can see that since the aqueous is not able to go through the pupillary route, it pushes the peripheral iris, it closes the angle. So this is the pupillary block that happens, and then the patient may end up with a post-acute angle closure attack like this, where there is a triad sign of Vogt present. So this is before and after. When we do a YAG-PA, you can see the same patient, how beautifully the angles have opened up in the periphery. So let us see a video. We'll have a more like a video based one. So I do a Van Erichs grading here. You can see that the Van Erichs grading shows the angles to be very shallow. You can see that the antechamber depth is very minimal in this video. So then I'm using an Abraham lens in this video. Focus on a crypt. So you have to see a crypt. I'm focusing on a crypt here. Then the photo disruption is being elucidated. That is, the ND-YAG is being given. And the gush of aqueous, you are able to see the gush of aqueous here, which is actually coming out, and I'm now making an higher zoom. I just want to hit another spot here. You can see that I'm taking my laser there. I'm focusing it on the bridge between the two openings here, and then an additional shot is given, and again you can see a beautiful gush, the pigments being coming out, and then I'm coming out, the zoom is being reduced, and you can see this is the real-time phenomenon that happens, and you can see the same patient how immediately the peripheral slit, you can see, right, the antechamber depth is definitely better than what it was. So this was one of the toughest videos to take, my dear friends. I think you can go back tomorrow and try. We took it with a smartphone, in an iPhone 12 Pro. So I was uniocularly doing it, sir, and it was very difficult. One of the most challenging videos to take is a YAG-PA video. I think when you go back and try for yourself, you'll understand it's very challenging. A surgical video was more easier to take. So this was with a Abraham lens. Let us see a video without Abraham lens. So once we refine our skills, and the patient is a good cooperative patient, see this video, my dear friends. The beam is again aimed. I am not using a lens at all. I've slowed this video, so this is done in 4K. The beautiful blue flame you'll be able to appreciate in this video. This is photo disruption at the highest order. You can see a beautiful blue flame now. Are you able to see it? I'll just show this once again. So this is a video where we haven't used the Abraham lens. So we wanted to really make teaching videos as to how we can show the beautiful photo disruption, because we end up talking about the ionization process, how they really happen on theoretical aspects. So I just thought, why not we have the good video on photo disruption. You can see that we have reduced the speed up to 10 times, and you can see a microephema that is coming down. So since I am not using an Abraham lens, when you are using an Abraham lens, you can just give an axial pressure. That itself will stop the bleeding. I have just edited out that part. You can ask the patient to close his eyes, put your thumb finger and just give a small press. That will help you in arrest this bleeding. I have done that, and you can now see that the microemphysema has stopped. And that is why we choose this area, the 11 o'clock or the 1 o'clock area, because we don't want the emphysema to trickle from a 12 o'clock point of view, and we avoid the 3 o'clock and 9 o'clock because we don't want to hit the major vessels. And again you can see that the Van Eyck's is being demonstrated, as well as a beautiful patency on the demonstration itself. You can see a retro glow. You have to put the retro. So this is a simple tip and trick. So this is a video that we have done, and I'll run through the theory. I think most of us will be doing the procedure, but I just wanted you to share the important tips and tricks along with the blue flame that we get in photo disruption. Do your grading by slit lamp. We have this is again another animation which we have made. So I believe in a video assisted learning, especially for neophytes, we show them what the normal angles are like this, and then we take them into a real time scenario and we do a cognitive match the following. We can see the scleral spur here, then you have the pigmented trabecular meshwork, then you have this is the non-pigmented one, and then the Schwalbe's line. So at every insertion, that is if the root of iris is slightly one step ahead on the scleral spur, and then it goes another step ahead. Yeah, I'm just winding up. So if it's one step ahead, that means the angles are slightly more closer, like 4, 3, 2, 1, and you'll have to grade your angles always, whether it always summarizes whether it's a open angle or a closed angle. And we did some beautiful videos on what is Van Eyck's grade 1, how are the angles visible, how will be the angles closed when you can see the complete closure. So this is one important point I want to make a notice. These are most of the indications that we'll be encountering, and in partially it has a role in plateau iris and a limited role in aqueous misdirection. So I just want to show one video and end this presentation. I want to skip all the theory part of it. Whenever you do PI, make sure it isn't very big. If it's very big, as in this one of my patients here, you can see the pupil won't dilate. So it gives a tough job for the surgeon. You can see the PA is almost as equal to a 1 millimeter or a 0.5 millimeter. So then we have to make sure we use a BX ring and then do the cataract procedure. So that is something I just wanted to make a note, and this biometry will always give you an idea whether you are dealing with a hypermetropic eye or not. Thank you, sir. Thank you for the opportunity.
Thank you very much. Wonderful. I request Arun to give a nice presentation. Just one question, Venkatesh. How do you decide on a spot size and energy for Indian pigmented eyes? You can take this.
Yeah. Sir, it's more with practice is what I believed, sir. When we start off slow. You start with a very minimal energy, and then once you give the first spot, and when you give it in the crypt, you'll identify that you will need a much bigger energy, or you are okay with this energy. So that's what is something that I still go with. I start with very minimal energies, 2 millijoules or something like that, and once the first spot is delivered, if it opens up well, you know that this is in the right area, you are at the sweet spot, or else you may need to slightly titrate your energy and then go for the higher one. Yeah. Which one, sir? Micro energy.
Maximum.
So maximum I would not recommend more than 6 or something, sir. It's not really advisable, because once the pigments have clogged and you change your energy levels more, you may end up having a corneal burn, or once the pigments are dispersed, in the first spot if you miss, you may not be able to hit the sweet spot in the second or third. You may have to change your position. So it's always not advisable to go for more energy, because you may not have hit it in the right area like a crypt. So it is better to avoid energies more than 6 or 7 for that matter. Yeah. Thank you, sir. Yes, sir. 1 is sufficient, sir. Yeah. No, sir.
You have a question? Yeah.
Ma'am, even today pilocarpine is something that we always need to keep in mind. Pilocarpine sometimes, which one? That's what, ma'am. When you use a Abraham lens, you will have an ability to actually, just like your gonio, you can actually move the lens because it has good coupling effect. You'll be able to move it, and you may be, if you're lucky, you'll be able to have a good view without the arcus. You just need to maneuver your left hand in such a way. You'll have to just go slightly maneuver and hit it where the arcus is not there, but you'll get a peripheral spot as well. It's more of a maneuver. You learn with more practice.
Okay, thank you. Topical.
Yes, sir. Topical.
Jerk.
Yeah.
That I think we
topical.
need to explain to the patient, talk to the
Yeah.
patient sometimes, But we can't take for a young PI, laser eye not be patient to the other area.
Yeah.
Thank you.
Thank you for the battery of questions. Thank you.
Very nice question. Now we have Dr. Anant. He's going to take us through the very, very important area of doing a YAG capsulotomy. I think that is, we need to know how to do it properly. Dr. Anant.
Good morning, sir. First of all, thanks to ISCA's team for including me in this symposium where routine procedures for general practitioners. I think each and every cataract surgeon would land up doing a capsulotomy. The incidence may vary from 20 to 30%. So there are some few interesting facts which we should know about PCO. There is no specific size or dimension for this. It's like amoeba. It can take up any shape. Whatever the technology, whatever the IOL things have come up, but still the incidence is high. Higher the age, lesser the incidence of PCO, and diabetics, because of this collagen activity and all, the incidence of PCO is less, and incidence varies from center to center, and majority of the patients, almost 42%, undergoes a capsulotomy 10 years after cataract surgery. So as I told, it's like amoeba, it takes various forms. It's just a membranous thing behind the IOL. So when do we do a capsulotomy? Whenever our uneventful patients comes back to us with reduced vision, either in terms of quantity or in quality, or sometimes you need to do some post-surgical treatment, you are not able to visualize, yes, you require this. The contraindications, if you are not able to visualize the posterior capsule because of any optical issues related to cornea or nystagmus, it becomes absolute contraindication. Related to contraindication, any active inflammation or acute inflammation going on, cystoid macular edema, and high myopes where the risk of RD is there, yes, it becomes difficult. So how to prevent or postpone the onset of this thing? The video runs? Yes. What I personally feel is we need to follow things. Our rexis should be between 5 to 5.5. The edge should cover almost or 0.5 mm of the margin, so it gets postponed, and very good cortical cleave up is very, very important. PC polishing, some surgeons do recommend, but I personally feel that good cortical cleanup itself will work out very well to delay the onset of PCO, and good hydrodissection. And one more, personally what I believe is rotating the nucleus post hydro 3 times clockwise or anti-clockwise. That will release up all the equatorial cells, which are the future proliferative cells, which causes the PCO. So these steps can be taken. The IOL factors, 6 millimeter, the square head technology, all this tries to prevent the onset of PCO. The angulations of optic-aptic angle also helps us. There are some other formidable ways, they are still in research level, not yet practical. So coming on to the YAG capsulotomy, we all know it's an 1064 and solid state, NDIAC, photo disruption. It produces the acoustic waves, it breaks down the capsule. So how to prepare the patient? You need to direct the patient, done a topical anesthesia, obtain the informed consent, because complications can happen, and make sure that you position the patient very well. They are sitting comfortable, because it may take around 30 seconds to 1 minute or so. You need to tell the patient to look into the fixation light with the other eye. So sitting position should be very comfortable. Video runs? Yeah. Adjust the chin rest height. Inform them it's done a topical, shorter duration. Focus it well, preferable in a dark room. So what are the energies we use? Most of the times we land up using 1 millijoule. Identify the stress lines, give a shot at the tension line. Minimum 4 shots is enough, either Christmas tree pattern or crochet pattern. Make sure that you will not leave any residual tags. If it falls in the antechamber, it's better because it passes out through the angles. So this is the procedure. You can just see here, focusing is very, very important. I just give 4 shots. See? I think this has been recorded with the handheld device, again with iPhone, slit lamp mounted. 1 millijoule, 4 shots, no residual tags are left out. It's a simple procedure. If you have to prevent the IOL pitting, make sure that you focus slightly posterior. The acoustic waves will break up the capsule well, and the threshold of antivitreous phase is slightly higher. From 1 millijoule, you may have to increase your energy to 2 millijoules. Yes, this is how it appears. So the capsulotomy size again, it should be as large as the pupil in the isotopic this thing. With the availability of new premium IOLs, if the patients of head-off lenses or triphobicoms, make sure that the diameter is almost between at least 4 to 4.5 millimeters. And this capsulotomy, whatever we do, they tend to enlarge post-operatively. That has been studied around 32% within 6 weeks. They tend to enlarge. So post-operatively, they usually mild dose steroids is required for a week, and no use of antibiotic. If you suspect small amount of iritis, you can taper down the steroids. Pressure rise do happen. If you suspect after 5 hours, go with topical anti-medications. Otherwise, if it's not required. Majority of the times, vision do improve in this sort of patient. If the vision doesn't improve, we need to look in for the other causes why it's not improving. The complications are very rare, but still, as I mentioned, raised IOP, CME can be exaggerated, high morbid patients are RD, and endophthalmitis is very rare, this thing, and more amount of energy iritis can happen. Thank you.
Thank you, Dr. Thank you very
Yes,
much for highlighting all these. Just one question, Anand. Nowadays we have so many multifocal, trifocal lenses.
Yes.
There, what should be the size of capsulotomy?
That's what, sir. What I was trying to say is, see, we need to understand what sort of trifocal or what sort of head-off we have implanted. We need to understand that we have a near addition component and the way the peripheral rings are placed. So personally, I believe should be around 4.5 millimeter should be ideal for all these premium IOLs. Anything lesser than that, intermittent vision might get affected and myopic vision.
Any questions from the house?
Yeah, that can be it. It's not a contraindication, so yeah.
Look, for doing YAG capsulotomy, patient needs to fix also. You want to hit in the right area. No point doing a capsulotomy in a non-pupillary axis. If you dilate the pupil too much, also you can may not have a centralized opening in these cases. So moderate sized pupil, as we talked about, should be used so that you can have a central opening in these cases. Unnecessarily very large opening not desirable also. So that is also very important. And too much of energy, too much of disturbance to anterior vitreous face going to create the complication is highlighted. We all know, especially myopic patients, you do have a higher chances of detachment, inflammation coming out, CME happening in these cases. So before doing a YAG capsulotomy of all these patients, apart from the picture he showed, it had a different posterior capsular opacifications, but there will be some other causes, maybe some other causes of decreased vision in these patients, especially a diabetic patient, old age patient. There may be a macular scar, there may be macular edema. Patient may have a severe ocular surface problems. Those things should be ruled out before you actually damage the capsule. Because capsule is a one good area which separates the posterior from anterior space. It can be safeguarding various things. So unless you are very sure that is the cause of decreased vision and patient going to improve after capsulotomy, we should be damaging this capsule with the lasers. Yes, sir. Yeah, it can be used, sir. Normally we give a steroid for the first few days a week. If patient still has inflammation, you can continue. Normally don't require to give more than 1 or 2 weeks. And the anti-glaucoma medication along with that, both for a laser iridotomy as well as for a YAG capsulotomy, because pressure sometimes might go up in these cases. Thank you. Thank you very much.
Better to dilate and do. Better to dilate and do. No, one dose of T plus is enough. I think it will go until 6 millimeters. Your zone. Yeah, that's what. One drop of T plus will work out. Make sure that it's around
Don't
67.
dilate too much.
Too much of dilatation is not.
Yes. Very small pupil also very difficult to focus and you don't know where exactly you're hitting. And you have to know your machine. How much defocus, how much focus has to be done so that you exactly hit the capsule and don't hit the lens. Because in the past we have had, focusing problems and many lenses you have a multiple pitting and even a lens will crack also. And silicone lenses, they have a multiple, craters sometimes. we have to be very, very careful hitting the spot in this case. Thank you again.
Yes.
Thank you Anand, all the speakers for making this session so lively. We are very thankful. The other people are already come to dethrone us. Welcome, Dr. Natarajan.